biggest challenge to molecular testing in the community is non-testing. A lot of patients are not getting guideline recommended molecular testing. And I'm not talking about pie-in-the-sky new rare mutations. There is a huge rate of non-testing even for EGFR in the first line, and that data is not new. And when patients are tested, in my opinion, testing is not always broad enough. So talking about the non-testing problem, I think education is one answer to that. Another answer, though, are non-invasive tests. Sometimes it's not safe to get it at the spot that needs to be biopsied. Sometimes the patient declines it. Sometimes the practitioner is afraid of hurting the patient by ordering that biopsy. And sometimes local expertise doesn't allow it. Non-invasive testing can answer all of these. So we're talking about plasma-based testing for cell-free DNA or perhaps urine testing. The advantage of these is they don't require a biopsy and they can bring molecular testing to a wider group of patients. The disadvantage is that not every tumor sheds DNA, and so an actionable change can be present, which is missed by these detection methods. The breadth of testing question, I think, is a function in part of cost. The next generation platforms and really broad platforms in general can be rather expensive, and turnaround times can be longer than we'd like. And I believe that's evolving over time. As the technology evolves, the cost is coming down. So I think that it will become more applicable to a larger segment of the population to just test for everything. The payoff has been remarkably the same across the targeted therapy indications, whether you're looking at EGFR as standard of care, ALK, ROS1, and even some of the newer changes that we're seeing in emerging trial data, some as little as 1 month old, for example, MET deletion 14. It's amazing how similar the results always are. If you have a patient with an actionable molecular change and you treat it, you almost always see a response rate of roughly 2/3, which is more than double what you expect with chemotherapy. Your treatment is almost always less toxic than chemotherapy, and you of course demedicalize the life of the patient by allowing an oral therapy instead of being in the infusion room every week or every 3 weeks. In my opinion, the best way to improve this communication is to do it at a multidisciplinary tumor board. I think there's something very powerful to having every expert related to a multidisciplinary question in the same place, looking at the same images, if there already is some, looking at the same pathology and having a conversation about it. Now that's not always practical in every context, but we do have these things called computers that you can video conference on, and virtual tumor boards are being used much more often in the community. I think this is a wonderful thing. And when that doesn't work, it's really a simple old-fashioned telephone call or email, direct attempts at communication. In busy practice, that can often be challenging. And this is where a nurse navigator can be very useful for ensuring that that communication is done properly. I would also say that redundancy is helpful. So if I'm ordering, for example, a biopsy for the purposes of T790M testing, I don't want my pathologist to use up all of that tissue, proving that it's cancer and proving that it's lung cancer. And so what I would do is, in addition to having called the molecular pathologist before ordering that, I ask who is ever doing the biopsy to write on the requisition. I usually supply this to them in a written form, typically email. I want you to write on the requisition, we know this patient has lung cancer. We know they have EGFR mutation. The question is T790M. Please restrict your testing to that. And what they'll do is they'll just do one H&E, simple slide, so that they know where there's cancer. They'll microdissect that and just test that either for molecular testing.